We usually aim to be finished early anyway, but I think we've usually gotten it. But the big red numbers will help us out. So I'll go ahead and call the committee to order. I got alibis from 3 of our members, from Drs. Beeson, Manifold, and Malone, that could not be here. But we do have a quorum with people here. So I'm going to jump right down to some feedback from GTAC from some of the issues we had from before to update the committee. And I just had a discussion with Jody that contradicted something of what I thought. He told me he wasn't going to be in here. Is he in here? Good, I can talk bad about him. There were 3 issues of interest to this committee that went to GTAC at the last council meeting. The first one was the recommendation for physician approval of continuing medical education programs, which we strongly support, that it is the EMS medical director who is responsible for the students' clinical activities. I have listed that was affirmed. I'm sorry, no, that's wrong. Pass on that. That was sent through to the Education Committee. The Education Committee has affirmed that. Now it will go to the council again for approval. I would assume there's no change in anyone's thoughts on that.
Dr. Greenberg, just for clarification, that's the EMS medical director of the EMS provider, not of the educational institution.
Correct. The EMS medical director of the provider, the ambulance, is responsible for the students, not the EMS medical director for the educational program. You're looking at me. Yes. Okay. Yes. Correct. I did. Yeah, I went that. That's why I went out of order. Yeah. B passed. A passed. That's where you have to have medical director for continuing education. That's why I was confused. B was affirmed by the Education Committee today and will go to GTAC for final passage. And then C, position statement regarding EMS transport to freestanding emergency medical care facilities, was passed at GTAC. One of the issues that GTAC has asked us to talk about is the scheduling of meetings, and I will hold that for the end. That's item 1D. I'm also going to skip way out of order to the bottom and ask for a quick presentation on the EMS data analysis. Where'd she go? She ran away. You're going to do it? Okay. This is the trauma system database, which we have heard of many times. They asked to be able to present to us. They asked for 15 minutes, and I said, can you do it in 5? We have very short attention spans. Also, I think I spent about a 30-minute conference call with them to tell them what would be of most interest to the EMS medical directors. What they would like to present is what they can do for us. I asked them to do a 5-minute presentation, give us 5 minutes for questions and for feedback. One of the things I did say is that there is a lot of frustration on this topic because we've heard about the database for a long time. One of the other frustrations is and I expressed that on this phone call, is we get asked what data do we want for our service, and my feedback is we have the data on our service. We don't need to send it to the state to get it back. So we would like it for comparison. So for that, I'll turn it on over to you.
Okay, thank you. My name is John Helston. As Dr. Greenberg says, we started to put this together to solicit input on what sort of canned reports with our new collection system that we'd be able to use for users. As he's told you, he made it clear to us that what he really wants is how can we get our hands on the actual data so we can do our own analysis. So this is real quick on here's what data are available and how you can access those. Access to the data, confidential data, public use data file, most recent data available and how to obtain it. Here's an electronic data file that's available. This is to stakeholders who have authorized access to receive data. This is more in response to Dr. Greenberg's comments about those entities that you are associated with, essentially your own data, that you can get those data back simply by all entities for which you're the medical director, all entities for the RAC, which has a business agreement with those entities. It's the data essentially that you've submitted. It's real simple. Send an email to this injury.web@dshs.state.tx.us. Goes through, that request will be handled with the information that you're requesting, year of the data that you're looking for, and then this comes to you in an encrypted email.
Will those data fields be blank, some of them, or they all have data in them?
They don't necessarily all have data. I mean, those are depending on the quality of the data that are reported to us.
And how do you know that I should have authorized access? How does that occur?
I'm assuming that there's some sort of official documentation somewhere that either between us and with regulatory that we say that this is what you have access, this is what you have authorized access to.
Do we know that?
Not unless your administrator has signed you up.
Okay, is that how it has to work? The administrator of the service has to sign up the medical director?
The administrator of the trauma registry, that doesn't necessarily mean it's the administrator of the service. They could have your IT person as the administrator.
I gotcha.
That person has to sign you up.
Okay. I have no idea who that is for me. Or, does anybody else have an idea? Nope.
Yeah, it didn't really matter because I'm just going to go to my database rather than asking you for
Right.
a copy of the data that's already in my database.
Right. Yes, and that's what I said. We're more interested in everybody else's info than our own, or comparing ours to somebody else.
So this more goes along with, this is a public
Okay.
use data file. It's a statewide data, does not contain protected health information that's identified under HIPAA. Okay, so this slide goes through some of those things that are not included in this data file. Names of individuals or names of entities. Once we get down to geography, we have limitations on zip code that we're able to release. Dates are restricted in terms of the month and the day. We can provide years, but with this public use data file, the actual date and or month and day are restricted. Social security numbers, medical record numbers, those personal identifiers are not included in this public use data file. These files include all the data that have been submitted to the trauma registry for that particular year.
Okay.
At this website is a more detailed listing of the specific variables that are included for each, for the EMS as well as for the hospital data. In general, the EMS data include these categories of information about the call type, the run type. We have dates and times on dispatch, on arrival, and on departure. There's patient demographics, information on vital signs, the cause and the type of injury, number of different fields on the procedures and treatments, and as well as suspected illnesses. On the hospital side, similarly, patient demographics. You have a Glasgow coma score at admission. You have a revised trauma score, diagnosis information, cause of injury information, severity scores, some pre-hospital data on transport and transfer, as well as some hospital charge information. Most recent data is for 2011. 2012 data is supposed to be available by the end of the summer. And then there's a process going on in which the EMS, individual records from EMS data will be linked to the hospital data so we can do some of those analysis on suspected or specific incidents and their outcomes. And so that's going to be available a year after that. Very short, very quick. Any questions addressed to our manager, Tammy Sajak?
And is she,
I mean, if you have them today, I'm glad to
Yeah.
answer them today, but after this.
yeah, so there's been, like I said, this has been a long time coming, talking about the trauma database, and now we have some access. So they really want to know, what do we want? And I said, well, what do you have? And so that's kind of what we have. So what can we tell them that we want?
Well, so for example, could you query that for the response time on every code 3 call for the year 20,000 or 2011?
Those response times can be calculated into those data files, but they're not automatically calculated.
But you'd have to process that yourself.
Right.
Yeah.
Through that public use data file, yes. One of the things that we're trying to do right now is trying to make, I'll contend that one of the fundamental reasons you collect data is to use that information. So, years of frustration, I understand that. What we're trying to do is to make these data available so that they're useful to y'all. What we understand is how do you collect information, how do you analyze information, and with help from subject matter experts, how you interpret that information. What we don't know is what information is really useful to you. And so the title of the slide is, what questions are you trying to answer?
And it'd be Excel format, comma, delineated data?
That PUDF is too large. It's over 2 million records. It's too large for an Excel file. We can give it to you in a comma-separated file, in a SAS file. We can find some format in which to make that available for your use.
If you're looking for feedback, as to how the data could be useful for us from a research perspective, one of the gaps that we've had is finding a way to match patients in the EMS database with a hospital database or with a trauma registry database. And I'm not sure if there's a key to that yet, but if we design a appropriately approved research project with approval for PHI elements, whether consent or exempt from consent, being able to match patients in that database with a trauma database would be very beneficial.
We agree, and this is exactly a process we're trying to go through. One of the issues has been, one of the most effective ways for us to be able to link those data is if we have names. So one of the issues has been getting patient names from hospitals specifically. So we're working on that issue, and again, we're working on trying to link those files for those purposes.
At the risk of asking a question I really should know the answer to, is the data going up to you, is it trauma only, or is it all records being used for trauma?
It's for on the EMS side, it's for all calls that come in. So it's medical, it's trauma, it's false calls, that's what the requirement is for reporting.
And that's very good. That answers my question.
Any other questions? Thank you, sir.
Okay, thank you.
All right. So, again, skipping around a little bit, one of the standing agenda items on here has been to review and propose additions to our medical director webpage. I don't know if Dr. Ellerby's on it right now or not. I can't tell. But if you would look at that, we don't have to discuss that at the meeting. I have looked at it, and most of the documents that we have approved through this committee that have gone to GTAC have shown up there. One of the ones that didn't is because I was confused and thought we had already approved the one about the students. But that should go on there. But everything else is on that website. But please refer people to that website as a reference source. Next, item number 3, I'll turn over to Dr. Bradley. This is a similar item to what we have already done on freestanding emergency facilities. This is a position statement about non-traditional facilities because there's so many different facilities out there nowadays.
Thank you, Dr. Greenberg. So just very briefly for background, this addresses the question about transporting patients to places other than hospitals that are not freestanding emergency medical care facilities. As a review, freestanding emergency medical care facilities are licensed by the Department of State Health Services, and they have stringent laws that they have to follow for licensure. They are allowed to call themselves an ER or advertise emergency care. Under Texas Administrative Code, if they are not licensed as a freestanding emergency care center, emergency medical care facility, they are not supposed to use the word ER or emergency. But nevertheless, there may be operate under other names such as urgent care center or a vast variety of other names. One of the challenges that we have, of course, is that to the best of my knowledge, not being an attorney and not having consulted an attorney, I did not find any Texas statutes or rules that direct how those facilities may advertise or what services they may offer. So an urgent care, someone could advertise urgent care, and you have no idea of what level of urgent care they provide. So the position paper then goes to discuss some of the questions that might be raised. Of course, from the hospital side or from the freestanding emergency care facility side, the question of diverting patients that are primarily funded away from emergency centers, leaving the emergency centers having a higher burden by proportion of unfunded patients is a concern. The other concern would be delay in treatment, although we really don't have any evidence, and to the best of my knowledge, there's been nothing published giving us any evidence to show us which way delay in care goes. For example, it may be that if a patient goes to a non-traditional destination by ambulance, that emergency medical care may be delayed because they're not going to a hospital emergency department. On the other hand, if they go to a hospital emergency department, particularly where I work, even if they come in by ambulance, they may wait several hours to be seen versus going to a non-traditional facility where they may be seen within minutes. So delay in care may go either way, and we really don't know which way that delay of care would go. The paper then goes on to talk about the same ethical questions that we talked about in the freestanding center paper, and basically the questions are non-maleficence, doing no harm to the patient, benefiting the patient, getting him to care as quickly as possible, benefiting the overall healthcare system, unloading overcrowded hospitals if appropriate, minimizing unnecessary governmental regulation, and avoiding financial harm to the hospitals. The bottom line is that we recognize that the issues in Houston are going to be different than the issues in Denton, are going to be different than the issues in El Paso, are going to be different than the issues in Spring. So this really becomes a local question, and our recommendation is that the EMS medical director be the one to decide whether or not non-traditional destinations are appropriate for their EMS provider. Thanks, Dr. Greenberg.
That is the transport to these facilities.
Transport to those facilities, that is correct. So that there would be no regulation prohibiting it, and it would be up to the EMS medical director for each provider to decide if it was appropriate or not.
Is there any protection against a lawsuit if you do restrict transport to a facility and they don't like that concept?
No, sir.
Sue you for it?
No, sir.
Maybe we ought to add that to new language in the future, so that the medical director is not under undue pressure from financial reasons.
I don't understand. What language would you add it to?
Well, if there are regulatory language for a freestanding emergency department, that would need to include language that would say that department being chosen as a destination is up to the local medical director with no legal consequences should that medical director determine that your capacities are not there for those patients.
So like indemnify and hold harmless for doing that.
In the event that you say, no, I don't want my broken hips going to that freestanding ER.
I've had that once happen where we deemed a place not be suitable, and the medical director of that facility called me on the phone and said he was going to sue me for restraint of trade. It didn't go anywhere, but that's what he voiced was. So I don't know if you could make language that would stick to indemnify you, but he made it clear if we didn't transport to his facility, his intention was to sue me personally for restraint of trade.
That's exactly why I think we need language that would protect you from that.
Yeah.
Something that says that this policy is backed by some sort of, legal understanding that there's indemnification in the law. Kind of like why you don't get in trouble if you report child abuse.
May I ask a question to staff? Would that be a rule, or would that have to be a statute? Thank you.
I think that's beyond what we can do here. It is in Rule 197, though, that the medical director picks the destination.
So if it's the will of the committee, then I would just insert a sentence that recommends that GTAC recommends, whatever the correct verb is, legislation for that purpose.
Indemnification of medical director.
If that's what we'd like GTAC to do, is to recommend that. I'm not sure what GTAC can they make a recommendation to legislature? Is that within their purview?
They could the GTAC could make a recommendation to us as a legislative initiative.
Roger, thanks.
It's not an issue now when the numbers are fairly small and their political presence is not that great. But if they become more adept at the politics of it, it may become an issue in the future, at least for us, when we decide that, you know, as a blanket statement, we're not going to take certain patients to those facilities.
It also may be something that needs to go to the medical board, because that's where that rule sits about the medical director selecting the destination criteria. They may have a better perspective on it.
Are you opposed to this position statement on that basis?
No.
All right, so you're not opposed to this, you're just wanting an
No,
addition?
just some additional
Okay.
protection. It's giving us the responsibility without protection, basically, which we have now.
I was going to say, it's kind of my job anyway.
Yeah, it's in the job, but could make the job easier.
Yeah, I'm trying to pull up 197, and it's taking me forever, but it's definitely in there. Any other comments on this? I would like everybody to look at the proposed recommendation language. That's really what would go forward more than anything.
Is this online?
This is not, no, this is not online. This document's not online. I see Dr. Elby's looking for 197, just like I am.
197.3, I had to answer this question today. 197.3, section B, little b, number, I think it's number 7.
So while you're looking, since this is not online, I'll just read the recommendation. It's just about 6 lines. The EMS Medical Directors Committee recommends that the EMS medical directors should, in consultation with local medical care facilities and in consideration of regional guidelines, determine the capacity and capability of non-traditional facilities in their area to receive EMS patients. The EMS medical director should determine if each EMS provider may transport to these destinations. Any such decision should be made with consideration of the impact on the overall healthcare community. If the EMS medical director approves, policies for these transports should be written into the EMS protocols and standing delegation orders.
You could certainly get the support of the RAC in that decision as well, I think, would be handy. But we don't have to say it in that, but I think it's something that would be politically smart.
Yeah. And I think obviously this would apply in areas where there's no acute care hospitals close by, or it's a difference of a 5-minute drive to a non-traditional facility versus a 45-minute to an hour drive to an acute care hospital would be where this might come into play.
Or one of the other items we have is mental health that we're going to talk about. That's one of the issues that brought this up. Would we be prohibited from taking people to an acute mental health facility? You know, and there's just more facilities popping up. So, any comments from the audience? Comments, questions, concerns? No. So I think got one. Okay.
Is there any verbiage that restricts the level of acuity that you would take to a non-traditional?
Who are you, sir?
Oh, one, whereas Texas Children. That would restrict the level of acuity of the patient that you would take to these non-traditional?
I'll speak for that. And no, intentionally that's up to the EMS medical director to make that determination as he or she sees as appropriate.
And it's very simple in Rule 197. If this is what Brett was talking about, I see item 13 basically says, yeah, an offline EMS medical director shall establish criteria for selection of a patient's destination. It's just that, it's that simple. So I have a motion from Dr. Bradley for approval of the recommendation.
Second.
Got a second? Any other discussion? Approved?
Aye.
Anyone opposed? Okay, so I will take this to the GTAC meeting on Friday with an additional recommendation, and I'll get Brett to help me with the language for what that should be about the, not hold harmless, but some kind of protection. I think it's part of the job.
I would look look in the statute under training liability. That might give you some words about for your courses. That's limitation of civil liability. That's got some language in there.
I didn't know there was such a thing. Did y'all know there was such a thing?
I'm not sure I understand what you
Yeah.
said.
Help us out, because I think you just hit something we don't know about.
In the statute, I can't quote the right part right now, but there's a protection for medical directors and training institutions to those who supervise and train people about civil liability.
In the context of training,
Training, yeah, of EMS personnel.
In EMS regs?
Yes, Chapter 773 of the Health and Safety Code.
773.
Okay.
while that may not really help us with this particular issue, it may be a good template to say, hey, we want to get, there's a precedence for trying to give ourselves some protection. Let's try to recommend that we get that same protection in regards to this issue.
Okay, so I will take that forward. Moving along, item number 4, discussion of mental health issues facing EMS medical directors. Dr. Kovar actually brought this up at our last meeting, and I do not see him. But put it on the agenda so we can have an open floor, open discussion about it. How it impacts everyone's practice, priorities, issues, just to get the discussion started. Anybody want to take a stab at it to begin with?
I think what you said was good. Is there an option to take someone to a more appropriate facility? I know certainly my ED does not have mental health services available. If there was a facility that did, I don't know if they exist, but if there was a facility that did, that might be more appropriate than an acute care hospital.
And aren't some of those being proposed? Aren't some of those being proposed by some current legislation for mental health patients?
Sobering centers? I don't know that that's legislative, but I know that they're popping up. Does anybody have a sobering center in there?
We do. But I think it's not an EMS destination.
So I think the mecca, if you will, on this issue, at least as an emergency physician is concerned, is we get a ton of psychiatric patients that are brought to us only for medical clearance, without a clear definition of what medical clearance means. It usually means check their TSH. And there's nothing we have to offer them. So what they are really being sent to us for is a place to feed and clothe and shelter until an opening pops up somewhere. So the wonderful thing, the thing we would really like is if EMS could go out there, do the medical clearance, and then go directly to an alternative destination. And I think the key thing for us to keep in mind is we want to make sure that either we don't create roadblocks to that process, or if there are any, we identify them and try to remove those and facilitate the process. That would do a real service to overwhelmed emergency departments with psych patients that they have nothing to offer.
I agree. Any comments from the audience? Any suggestions? What we can do or what GTAC can do, what the state can do to help with this problem? It's awful quiet in this room. Have you noticed that? So what could we do as a committee to, could we do a similar, I mean, the position statement we just approved actually should help with this. It doesn't specifically say mental health, but it says alternate care facilities. Are there other things we could do? Thoughts?
There was a bill that died in Senate, or a House bill that died, House Bill 245, that was talking about training for EMS personnel on mental health patients. I think it was probably going down the road that you're talking about, that EMS personnel evaluate and transport directly to mental health facility.
Yeah, that was House Bill 245 by Menendez. Actually, Menendez is in San Antonio. That was about physician holds and EMS-initiated mental health holds. It wasn't about clearance. That took most of us by surprise that was in there. But that is the first time I think EMS and mental health have been thrown in together. Well, yeah, you know what I mean. But I guess the question to even throw out there is, what if a medical director wanted to delegate the medical clearance to his paramedics, special trained or otherwise, and how would we sell that to mental health facilities? Would that be something people would be interested in? And again, to try to give support to the services in doing that.
Well, I think that's the key issue, because I think all of us at this table would say, well, absolutely we can delegate that, and refer to the medical board and say we have the unlimited ability to designate and delegate our practice. I think the real question is there anything we can do to convince the mental health facilities, which are very interested in the thyroid stimulating hormone levels, that a paramedic without a TSH level can clear the patient?
There's an Attorney General ruling in 2009 by Greg Abbott in which he said that mental health facilities are not statutorily authorized to require a patient go to a medical facility for those exams.
And
so
yet they do.
The way the law is written, the Sheriff's Department is supposed to transport them to the mental health facility, not bypass that and go to a general hospital. That's the rule that he set out in 2009. It's just that nobody read that or cared about it. So maybe we ought to just make a copy of that ruling and distribute to all mental health facilities and ask them for their comment and see whether they oppose the Attorney General.
Dr. Greenberg, Dr. Jarvis made a very good point about what it's like in the emergency department with patients with mental health issues. And that's probably true in every moderate or large-sized city, if perhaps not even throughout the state. And maybe this might be an issue that the Medical Directors Committee could look at from the EMS perspective and perhaps work with an organization representing emergency departments or emergency physicians towards finding out a reason why aren't there more mental health facilities willing to accept emergent patients patients with emergent mental health conditions. Probably there's no incentive for them, and perhaps come up with a proposed solution to incentivize mental health facilities to take emergent patients that may reduce the burden. And of course, the challenge is not just for poor emergency departments, but it's not good for the patient because it's delaying sometimes for hours or days the mental health care that they actually need if there's no mental health specialist available in the hospital.
Not to mention exacerbating their condition.
Right.
That may require additional funding from the legislature in terms of being able to hire internists who would then facilitate that exam. I just think psychiatrists do not like that piece of, that's why they got into psychiatry. They don't like the physical part.
Absolutely. I guess to formalize my proposal is that we consider partnering with at least TSEP, if not TSEP, and I don't know if there's a Texas ENA, about perhaps creating a white paper on the scope of this challenge.
I think the one thing that may be useful is if in that group we can work with the folks from the mental health facilities and actually get a definition of what medical clearance is. My very cynical view is it's a euphemism for stalling, but if we could actually get a medical definition, what is it that you're looking for, rather than who can do it. If we ask them, what is it you're looking for, define it, and then it's up to us to figure out how to do that.
Well, the problem is that what they may be looking for is insurance status and residency status.
It would be nice to actually get them to say that.
Yeah. When they comment about Attorney General's ruling as well.
So I'm struggling for what to put down as our item for this committee. I agree about TSEP and the Texas ENA and all, but what do we do from this committee? Because our job is to advise DSHS and to come up with ideas and thoughts. Would it be, and this may go the line that I worry about between DSHS and TMB, would it be appropriate for us to consider what would be appropriate for a pre-hospital provider to do as far as medical clearance? as so far as to check a patient who has a history of mental illness, who is off their meds, who has a normal glucose, fits certain parameters, would be appropriate to go directly to a facility that would accept them? Or just to say that it's within the purview of the EMS medical director to do that?
I don't know if we'll be able to do the urine drug screens that many of them require, or actually do a blood alcohol level that means something that's significant for legal purposes. That's something that changes by day of week.
Right.
What blood alcohol do you accept, as a psychiatric facility?
One of the things that perhaps we could recommend is that DSHS facilitate that meeting.
A joint meeting between psychiatry and emergency medicine. And
I'm
EMS.
assuming there is a psych organization.
There is.
They fall
So
under dishes, right?
I don't know about that.
I think that's psychologist, but I think psychiatrists are outside of DSHS.
Yeah.
Because they're going to fall under TMB just like we do.
But their facility is under dishes though, right?
Yeah.
The inspections of the psychiatric facility.
I think that's correct.
Yeah, psych hospitals are under DSHS.
Yeah, they are.
And those administrators are the one, it's usually the administrator that's holding back the process. They're not accepting our patients. Before we can ever talk to a psychiatrist, there's a roadblock that happens prior to the physician-to-physician conversation. And it's not of our making. So the facility has a way to check financials or check whatever and make sure they don't get somebody that has alcohol or make sure they don't get somebody with certain drugs.
Should we start with just defining the scope of the problem before we try to get everybody involved? Anybody want to take a stab at that one?
I'd say it's only 100% of ERs have problems.
Yeah, well, yeah.
It's a pretty big scope.
Yeah, all the ERs and all the EMS have trouble with this. And law enforcement. Law enforcement is a big part of this as well.
Going in direct contradiction to what my mentor taught me to do, I'll volunteer to do that.
Well, I was going to recommend Manifold since he's not here, but we'll take you.
I withdraw my last statement.
No, that's a. Thank you, Dr. Jarvis. Let's. So for the next meeting, we'll have something to look at to give us some scope of the problem, potentially identify the players, and try to give some direction to DSHS. That won't take long, of course. All right. Moving on down the agenda, items number 6, 7, and 8 are actually all kind of together. We had a meeting of this committee at the TSEP annual meeting in Frisco back in April to specifically discuss some of the items that were placed in the Texas Medical Board rule that were referred to DSHS for action. Item number 6, which I'm not going to read off, asks that DSHS approve offline medical director courses for the EMS medical director to take. That's kind of the short story of it. We came up at that time, and I do not have it in front of me, with 2 courses. And then Jody Harbert came up to me in the hall and said that North Texas is willing to do a 1-day, 8-hour course as well for the EMS medical director. That has been forwarded on to DSHS. I do not know if that has gone forward to the medical board yet or not. Do you know?
I don't have an answer for that.
Okay. So we will have even another course to add to that. That would bring us to 3 courses as recommendations. Item number 7 is a little more difficult. These are the factors to consider when a physician requests a waiver to be medical director for more than 20 EMS providers. We talked quite a while about forming an advisory committee to DSHS, and Jane, who I guess has left already, we had a discussion after that. She is having to kind of run that up the flagpole and see if a true advisory committee can be formed. We're under all the rules and regulations and everything else. So we still have to, we as the committee have offered our individual and joint assistance for that process, but the structure of that has yet to be officially determined. We thought it was not advisable to come up with a checklist of things that people had to come up with because there's so much variation out there in the services that would ask for, or for the physicians that would ask for a waiver. So that's still a work in progress. I think that's news to most of the members of the committee because I couldn't send that out by email since, but we are still working on the advisory committee or advisory component. Has anybody thought of anything else? I think most people here were at that committee. No. Okay. Item number 9, I'm sorry, we've already done that. Okay, I'm going to go back to item 1D, GTAC committee and council meeting schedule changes. Do we have somebody that can run the computer for us, please? Where'd she go? So, as everyone knows, there's been ongoing discussions about the structure of the council and committee meetings. Recommendation for 2-day meetings. We'll have to pull it up on the screen. There's a quick visual presentation that shows the current recommendations for meetings. We have been asked to rank those meetings in order, the schedules in order of our preference. There are 5 different schedules. There's been actually 2 additional 6s. One 6 is leave it the way it is, and the other 6 is I don't care. So here's the presentation, and then we'll go through these. All the schedules begin with a 1-hour council meeting. So the big council would meet, get reports that are sometimes replicated between committees and try to set the tone and to give the committees some direction. They all allow for 10 committees to meet during the 2-day time period. The second day always begins at 8 o'clock in the morning, and all of the schedules end with a 2-hour GTAC meeting. So here's one of the, and we'll go through these somewhat quickly because at the end is a summary slide. So the first option starts at 1 in the afternoon. It ends at 4 o'clock on the second day. All of these meetings are 1 hour, so every committee would have an hour. Next slide, please. Option B is essentially the same as option A, but it shows each meeting to be 50 minutes. So it takes 10 minutes off of each one of them. That may reflect reality a little bit better. So A and B are very similar. Option C starts earlier. It starts at 10 o'clock in the morning. It goes until 6 o'clock in the evening. The second day ends at 8 o'clock at night, again with a 2-hour GTAC council meeting. And that's because on this particular schedule, all council meetings get what they get now. I'm sorry, all committee meetings get the current schedule of 1.5 hours for every committee. Next slide, please. Option D starts even an hour earlier than the last one, starts at 9 in the morning, ends at 5:30 on the first day, then runs from 8 a.m. to 6:30. It includes time for lunch, as does the last one. All but 2 meetings are an hour and a half, so a couple of the committees would get 1 hour. And this does not mean that the same committee would always get the same amount of time. And then the final option placed up, option E, starts at 8:30 in the morning, goes till 5. Second day ends at 5, has an hour for lunch. And the reason lunch is in here, I'll say, is there's a lot of people that I think correctly say that lunchtime is a networking time. The time between meetings is a networking time. And then the day ends at 5. This is a mixture, half and half, of hour and hour-and-a-half meetings. And that would be determined, it would be determined somewhat ahead of time as to who gets how much time depending on the amount of business they have. So our committee is asked to rank these 5. Can you go to the next slide? Here's the summary slide showing the 5 options. going across, what time day one begins, what time day one ends. Day two always begins at 8, so that's not on there. Whether or not lunch is included with the first two, it says not applicable because it starts after lunch, supposedly for some people. And then the number of hour and hour-and-a-half meetings. A lot of the discussion around this has had to do, too, with the reason the length of the meetings is there is because some people have said an hour is not long enough. They would need an hour and a half. The start and stop times have to do with travel, people having to travel from specifically El Paso, Lubbock, Amarillo has been mentioned, what time they can get in. We did look at flight schedules, and from anywhere in the state, you can get into Austin by noon. So getting here by 1 o'clock would be reasonable. Last flight out is 6 o'clock. So a meeting that ends at 6:30 would be too late. And I don't want to speak for some of the people in the audience, but they've also said it doesn't matter when it's that tight, or I have other meetings anyway, so I'll still have to stay an extra night. So the goal of this is to condense the meeting down, to decrease travel, and to decrease some of the time of the state employees. If we can knock one day off of this meeting each quarter, that's 4 days. Some of us pay taxes, I hope. So we all have a vested interest in this. So time is money for all of us. So I'll open it up for some discussion, and then we have to rank these 5. And at the end, I'll ask don't care or leave it as it is. Any discussion?
Well, I hesitate to ask this, but I'm assuming that there was a consideration of concurrent meetings, and we decided we couldn't do that.
Correct. Concurrent meetings was a big part of previous plans, and it was fairly universally disliked. So that was pulled out of all of these. Any other discussion?
E seems to be the most flexible in that you get half and half.
Can you use the microphone?
Half and half, 1 hour or 1.5 hours, depending on the needs of the committee. I would think that would give the most flexibility. The times are fine. 9 a.m. If you're lucky enough, your meeting doesn't start at 9 a.m. on the first day. You don't have to worry about getting there from any part of Texas.
I think my last choice would be C, as in Charlie, because that locks almost everybody into another night or a drive, perhaps several hours into the late hours of the evening, which might be not ideal.
Okay, well, go ahead.
I'm fortunate I live close, so I'm going to go with F.
F.
Okay. And that's actually one of the things I would like to report. How many of the members, it doesn't matter, and I think this is true for a lot of committees, how many members don't care because you're just going to come for your committee and go home? You stay.
I go to several.
Yeah.
I stay for several.
You do? Okay. So it's kind of split half.
Depends
and
on the
half.
agenda items.
But that said, E does look most flexible to me, too.
Okay. So let's do this as a committee. It sounds like E. Can we put E as the first choice?
Right.
All right. And we were asked to rank these. I see A and B as almost being the same. Same time periods, just the difference between an hour and 50 minutes. So I'll put A and B together wherever they go, so that really gets us down to the 3 choices in order under E. It's already been said C seemed to be the least desirable because stopping at 8 o'clock at night probably doesn't help much of anybody.
Agreed.
Would that be agreed? Okay, so we will put C at the bottom. 1, 2, 3. So now we have to rank basically between the top 2 as 1 and D. So the difference being D has 2-hour meetings, the rest are an hour and a half, and A and B both have essentially 1 hour, all the same 1-hour meetings. Obviously D goes later, starts earlier and goes later.
If we like flexibility, which it seems like we do, D seems like it'd be more like E than
Okay.
AB.
Agreed. So I would put it E D, A, B, C. Does that work?
Yeah.
Okay. And then where would leaving it as is factor into this?
I would put it at the bottom. I agree, it's be nice to save the money and get that in
Okay.
space.
Be okay?
Mhm.
And where does I don't care fall in? Nobody wants to say that. Nobody wants to say that. Okay.
Dr. Greenberg?
Yes, sir.
Can I- One of the things to go along with it, if we could pass along the request that the meeting schedule is established as early as possible, ideally 2 months in advance. I understand the requirement to publish the schedule publicly. However, it is sometimes challenging if the schedule changes after some of our work schedules have already come out. We've already planned to have off one day, and then it ends up that the medical directors meet on a different day.
And I try to pass that along as soon as I get it, but I don't remember when I get the meeting date. I think it's about 6 weeks.
Yeah, I like the 2 months. I think that
Yeah.
most of our doctors are scheduled out that far.
All right. No, I agree. I will request that. Do you remember, Dr. Ellerby, because you used to get it as well? Isn't it like 6 weeks or?
It seemed about that long.
Yeah, it's
And of course, you can't decide on whether you need an hour and a half till you kind of know what your agenda is. So
Right.
that means that we have a responsibility to make sure and hit you up with all of our topics well in advance as well.
okay.
Where is?
All right. Where are we at here? Seriously? I have it listed that we have gone through all of the agenda items, the specific agenda items. Summary for the GTAC meeting. We will be taking forward the position statement that we just voted on for transport to non-traditional facilities to GTAC. I will let them know that we are going to look at the scope of mental health problems and ask them to put that on the next GTAC agenda in case we're lucky enough to be able to approve whatever comes to us next month or next meeting. I know that's a little optimistic, but it saves us a quarter every time we can do that. I'd like to open this up to general comment and public comment. Is there any public comment?
And while we're waiting for Dudley to come up, can I just ask the other committee members to, on the mental health issue, just to email me bullets on things that you would like to see in that position, just to help me with it?
Okay. Everybody get that? And did you see Dudley get up before you said you'd wait on him, or was it? Okay, all right.
He just
This is
knew I'd
fine.
be slow.
Yeah, we figured.
We had a little talk about foot issues earlier. Just a quick thing in our meeting this morning, one of the rules suggestions we made in 157 recommendations from the EMS committee was more of a peer-driven process in some of their regulatory issues, and also for publication of a discipline manual, much like the education manual. And we haven't quite heard back from that, but the topic you guys had about having an advisory group of physicians that could help in some of those issues, I think maybe if that goes forward, or if ours goes forward, if they both do, we may actually want to have some cross-breeding in that group so that both types of issues could be handled, or maybe, I don't know if it's necessarily need to be two groups, maybe it could be one group that handles both with some physician and EMS operators in it. But anyway, I just wanted to let y'all know y'all aren't the only ones talking about something like that that could help the regulatory process. The EMS committee did as well. And when they get 157 ready to start talking about it, we'll find out how well that suggestion went over. But our committee suggested I let y'all know because of the discussion y'all are having on that avenue. So.
Now, is that all of 157 or something specific?
Yeah, it was the
whole-
157 we did before. We're waiting. They
Right.
got delayed with the legislative session, but I think Jane said sometime, hopefully before November, maybe cross your fingers and count backwards or something, and maybe we'll get there. So,
Okay.
So
click
are
your
you-
heels together. There's no place like 157.
Are you proposing how many people in the advisory, and like
I
two
can't
from each
remember-
committee, or what are you thinking?
Ours was more of a peer process in the discipline thing, but hearing some of the discussions, some of the members of the EMS committee were at your meeting in Dallas, and talked a little bit about y'all's idea of being able as an advisory thing, and that may be a better role for some of the EMS operators. So we just wanted you to know we were talking about something very similar. And if either one of those two topics start, or either of those two ideas start to gain some shape, we may want to have some more discussions together about that.
I think that's a great idea. And if we had at least enough representation from each of the committees, or sort of maybe a couple from EMS, a couple from education, a couple from medical directors, PEDS and others, trauma, at least one or two.
Yeah, it could help in a number of different venues, potentially. So, I mean, I don't know. It's kind of like y'all's, y'all don't really know if it's something they can do yet, and neither do we. So, but it sounds like we're having some parallel thought processes in a couple of areas. So.
Well, and theoretically, it would be GTAC, but GTAC can't move quick enough to.
Yeah, and ours
come
was
up with
really
these.
something separate of GTAC, and it was folks that would want to serve in that role, and it would be very limited, and it would rotate frequently, so that you don't get people that are entrenched in that type of role that, you start getting different type of power or groupthink issues that happen. And so ours, we didn't spend a lot of time, but we did talk about it as more of a peer review discipline type of thing, and we kind of structured it that way. But depending on the route you guys are taking and whatever DSHS says about our idea, we may still be able to get something that would help in some of those areas. Isn't that a really big clock?
Big one.
Big clock. It's counting down to rush hour is what it's doing. I think we're past rush hour, actually. So. All right, any other issues? Oh, what? Who knows? Come on.
Just wanted to introduce myself to the committee here. My name's Sam Vance. I'm the new EMS for Children Program Manager.
Yes.
Dr. Shaw said I should come up and say
Yes.
hi to you.
Yes,
So-
you sent me an email wanting to be on the agenda, but it was
I
too
did.
late for the agenda. Again, we're caught between the agendas come out too early for a lot of people that want to be on the agenda and too late for our work schedules. We definitely do not have the sweet spot on the agendas, but that's why. So you have the floor.
Well, thank you. I appreciate that. But like I said, I want to introduce myself to you. Just a little bit about myself that I'm sure other folks in the room are tired of hearing from me. But I started in EMS in 1987 with the City of St. Louis, Missouri, EMS. Worked there for 5.5 years, and then went to work for the Metro West Fire Protection District in St. Louis County, Missouri for 14 years. Had one too many back surgeries. They said find something else to do, so I did. I became the EMS educator at Ozarks Medical Center in West Plains, Missouri for about a year. Was also the American Heart Association Training Center coordinator there. Came back to St. Louis and became the EMS outreach coordinator for St. Louis Children's Hospital. In that role, I also was involved with the pediatric subcommittee of the Missouri State Advisory Council, as well as the EMS for Children program in Central and Southern Illinois. So that's my connection with the MSC program there. And I'm happy to be here in Texas as the new EMS for Children program manager, and look forward to meeting and working with all of you. A couple things that are coming up that just to make you aware of, if you're not already, next week is EMS week, and next Wednesday is EMS for Children Day. With the transition period, we didn't have a whole lot of time to plan anything for that, but we do have some things that we're looking at for next year. Next year is the 30th anniversary for the EMS for Children program, so we'd like to try and do something a little bit bigger for that. Excuse me, and the next big thing that's coming up is the EMS reassessment is happening on the national level. You may remember in 2010, the EMS for Children program did the EMS assessment. Well, they're doing a reassessment now of all of the services across the country. And our cohort starts later this year in October. I'm currently starting to send out letters and emails to all of the different agencies to get updated contact information. And any help that you all would be able to give me with that would be greatly appreciated. Any help from anybody else out here would be greatly appreciated. Just so when those surveys do start coming out from NEDARC that they can get to the right folks.
Sam,
So,
do you know how to get all of this committee's email addresses? Do you know how to get them all?
Do I know how to-
They're on the website, the
Yes, sir.
GTAC dishes under medical directors list of members. And you can email, if you'd email each of us your contact information, that'd be helpful.
Okay, I will do that. Thank you. But again, thank you very much for your time. I appreciate it. So,
Thank you.
Welcome
And-
to Texas.
thank you.
Yeah.
Any questions for me while I'm standing up here, other than that one?
That's great.
All righty.
Can you say howdy in Gigamaggies?
Can I say howdy and what? Just say howdy. No, all right. All right.
We'll work on you.
On the advice of people in the audience, I'm going to have to say no.
Don't listen to them.
didn't ask maroon versus burn orange.
Well, it's an obvious answer. Why ask obvious questions?
All right.
All right.
Yeah.
Thank you.
Yeah, how did we get this color tablecloth anyway?
Somebody who clearly has good taste.
That's right.
All right. All right, any other comments from the audience? Anything else from the committee for future agenda items? Items of interest? Can we adjourn, actually?
Yes, please.
We are adjourned. Thank you. Thank you, sir.
What? Yeah. Got us out in an hour, didn't
We're getting
we?
an hour